All right, we're live. Everybody, this is Dr. Michael Kaye with the Center for Functional Health, and I'm honored to have with me today a very special guest, Varun Kunwar. Varun is a licensed professional counselor. He's also a certified clinical trauma professional, and he does EMDR, which I'm really excited to learn more about tonight. I've referred a few of my patients for EMDR, and they have done really, really well. So I'm looking to learn more tonight, looking to share stuff with you. So, Varun, welcome. It's great to have you on.
Thank you for having me, Dr. K.
So I always like to find out, where was everybody before they decided to do what they're doing, right? So what is your hero's journey? So you're sitting back in ninth grade somewhere. I don't know where you were raised, and you're going, hey, this is what I want to do. So how did you get here?
It's I think it's a profession that kind of chose me. Um, I was maybe in undergrad, I did major in psychology, minored in business and sociology. So I enjoyed learning about interactions with people. Um, and I really didn't know what I wanted to do with that. Actually, after college, my first job was working at a residential treatment facility. And it was for juvenile sex offenders. So everyone there was court mandated. And what I found was just the brokenness in relationships in these kids' lives, many of whom were perpetrated on themselves, kept this cycle of pain going. And despite what they had done, it was very a very humanizing experience for me, where I saw how therapy was helping to change these kids' lives. You know, they were in graduating with success and going on to live healthy, happy lives with healthy relationships with women. And I think that kind of bolstered me to learn more and to gain more experience in training and education in psychology. And ultimately, I got to the place where I am today when I started taking a training on trauma, and that really kind of opened the floodgates where as a clinician, I really started to feel very useful, uh, and to have tools and instruments that can help people really recover from traumatic events in their life. That there was no going back after that. It was just being able to see people be healed from horrible things like death to miscarriages to sexual abuse, for them to say, you know what, that doesn't hurt anymore. That's what really kind of kept on pushing me forward through the process.
Fantastic. Well, I'm glad you've chosen this profession, because I can tell you more and more people are in need of this kind of help. And we're finding it's hard to get in somewhere. We're finding like it's not easy to schedule. Sometimes it's insurance issues, sometimes it's financial issues. So
Certainly.
there needs to be more people that do the work that you do. And your work is really based in trauma. And I don't think people understand what trauma actually is. I mean, we think of trauma like traumatic injuries, motor vehicle accidents, which are very traumatic and can play on us emotionally as well. I get that. Some type of injury, a diagnosis can be very, very traumatic, not just for that individual, but for their loved ones as well. So I want to see if we can touch base on that. But we brought up a little bit beforehand, as men, there are things that we may have had that would be considered trauma, but it's thrown under the umbrella look of, like, you know what? Pull up your big boy pants, and this is just the way it is. Keep moving forward. So you got bullied. What's the big deal? And it is traumatic. So can we talk a little bit about men and trauma and what is considered trauma to men? But do you think it's just like, oh, that was just the normal way things were? And just because things are normal doesn't mean that it's actually right.
Exactly. Man, that's such a great question. It's a very, very layered question, because you're incorporating trauma and then also the socialization of men as a culture. And culture changes from location. So the culture for men in America might differ from region to region, but it certainly differs from the culture of men in Africa, for example. So the cultural aspects, when you layer that with trauma, can become difficult to separate. Um, and though there is a certain amount of overlap, I think there's a level of uh, grace that we need when we're addressing trauma for men and women, but we're currently talking about men's issues. And to be able to give them the ability to be hurt. Um, I saw at some point, there was a gentleman who went to Brene Brown conference, and she had signed books for this man's wife and daughters. And it turns out that Brene Brown didn't actually incorporate men in the first half of her research. I think, and maybe after this point she did. And the concept of shame was brought up. And he said it's interesting because from his point of view as a man, his wife and his daughter would rather see him die on his white horse than to fall off it. Right. And so the thinking behind it becomes, I have to withstand pain without any potential end, which is why men are higher in rates of suicide. If there's no possibility for improvement or life getting better, and life is just going to continue to be pain, if I talk about it, I'm going to be called a sissy or a wuss. There's got to be a way out. And it's a terrible thing that's happening. So I think that to give grace to men would be to allow them to open up, give them the permission as a society. It's okay for you to open up and share. And I think that that's going to come from men. That is a message that men need to be sharing with other men, saying, dude, it's okay. Let's talk about it. I'm here for you. And not to stigmatize other men who are suffering just like they are. So to hide behind this bravado is not going to help anybody.
But we're so instructed to compartmentalize as men, right? I do wonderful to compartmentalize. I mean, it's a much easier way to deal with things, right? You know,
Yeah.
this goes in this box, this goes in this box, and we don't let the two boxes touch, right? So,
Exactly.
let's not ever do that. Let's not have that happen. But we're also receiving, different messages as men as well. I mean, when you go by the billboards on the highway, it's like, if you buy her this diamond ring, she will really love you, right? So we're defined again by our money. We're defined like how well we do. Before it would be like, what animal can we bring back to the cave to feed? So what would you say to young men to get away from that type of messaging, that you're more than just your job, you're more than just your money, that you are a human being with feelings?
Man, it makes me think of he was in apologetics, Ravi Zacharias. He was talking about being away from home because he did ministries and stuff all around the world. And a quote that stands out for me, he says, I can't wait to be home where they love me for who I am and not what I can do for them. So I think that for young men, if you're looking for a partner, it's not going to, having money is great. It's fine. Having a nice car, that's fine. But if that is why somebody likes or loves you, then what happens when you lose those things, right? And in that sense, we're essentially making love and loyalty conditional. And that is a toxic cycle, because that means that I always have to be getting more. Because if I want more love, I need to provide for more things. I need to have more money and a better car and a bigger house. So it's not about the character of the man that matters at that point. And so I think that for young men, that's the most important thing. Work on your character, develop your character, be a person that you would want to be friends with, and find people who are going to value you for who you are and not what you can do for them.
Beautiful. That's beautiful. And I love that quote too. So let's turn the tables to trauma. So
Sure.
what kind of trauma, again, not only do women have, but men have, that, well, that's just part of growing up, or that's just the way it is, or everybody did that, right? So it all often falls all under that umbrella.
You had mentioned bullying earlier. I think I have a lot of different thoughts, a lot of different compartmentalized boxes that I don't maybe want touching when I think of this. But the idea of bullying, it can certainly be, and I think most often, is a very damaging kind of relational trauma that exists. It's relational and emotional trauma, because essentially the message that these other kids are telling you is that you are somehow inadequate or unlovable, right? And so when people experience trauma, they usually buy into a lie, right? So in my EMDR work, for example, there's always a negative cognition that's at the core of a particular trauma. And what we work to try to do is we try to reverse that negative core belief into a positive one. And so in essence, what we're doing is we're healing the person's identity of self, right? So not only is there biological work happening in the healing of the trauma, there's identity work happening in the healing of the trauma. So bullying is one of those things that I think many people go through. and men and women experience it differently. For men, for males, it's oftentimes more through physical aggression, and for females, it's more so social bullying. So, dropping innuendos or making up rumors or things like that, creating lies that will, degrade the character of a person. So it happens in different ways, and I don't think that's okay. Um, and then there's kind of like a fine balance between that and having normal social consequences. So, for example, if I'm somebody who chooses never to shower and then I go to school and someone says, "Man, you smell bad," well, that's not necessarily bullying. I'm not showering and I have horrible hygiene. Maybe there's reasons for that. I need help with that, and that's fine. But there might be some value to society being able to look at a particular type of behavior and say, that's maybe not okay or unsafe or unhealthy, and that needs to be addressed. We do that currently with criminals, for example. If somebody breaks into your house and steals something, society looks at that and says, that's not okay. We're not going to put up with that. And so there is a line, but in terms of trauma, for example, bullying, it's a terrible thing to experience.
It is, and having been on the other side of bullying, it is not, it is not fun, and it sticks with you. I mean, there are still things that just stick with you as you move on through life. You remember certain things. I will say, girls are meaner than boys. I mean, we'll punch each other, shove each other, but the girls say some really mean things to each other, and
Certainly.
I hear things from my wife, and my daughter, and my patient, like, wow, you guys are really mean. So the punch will go away, but some of the meanness, just some of those
Yeah,
words are very biting, can stick with you, and that can be
absolutely.
very traumatic. So in my world, we see trauma in the sense of those who suffer with a long-term diagnosis. We
Sure.
see trauma with those who suffer with chronic pain, and nothing is specifically diagnosed, but they carry the weight of the world upon their shoulders, and this develops into a physiological effect where maybe there's migraine headaches, there's neck pain, there's numbness and tingling down the arms and hands. There's brain fog. We'll see that as well. And I have the opportunity, and I'm fortunate to, when I treat people, to really kind of almost peel back the layers little by little. And there are times where, like, you hear something like, okay, now it's time for professional help, like by someone yourself. So that's really important. So when we talk about trauma, and you already dropped the EMDR, that's what I want to hone in on that tonight. So if you can explain what EMDR is and how it works, and then one of the questions I'll have for you is, like, who's not a candidate for EMDR? So when you're assessing a patient, are you
Yeah.
ever kind of like, okay, yeah, I know this is a phenomenal and a great technique, but this is not the candidate for that type of technique?
All right. Great question. So EMDR stands for eye movement desensitization and reprocessing. So without going into all the sciencey stuff, essentially what happens is that somebody who experiences a trauma, this is the analogy that I give to folks who might not be aware of trauma and how it works, is if you imagine a spider web, and kid walking down the street throws a rock, goes through the spider web and makes a hole. The spider can't access that area anymore. It can't go across as easily as it used to be able to. Now it has to kind of go around the damage, right? And that's essentially what people are doing as well. So going back to the idea of bullying, when somebody says something mean to you, they tear a hole in how you see yourself in the world around you. And now to address or approach that damaged area becomes painful to us. And so, like most people, we just avoid it. I'll try not to think about it ever. I'll never go to that place again, for example. I'll never do that activity again. Stuff like that. So more often than not, we end up avoiding or trying to what's called master our trauma by getting it under control in some way. Avoidance is usually the most common one. So what happens with EMDR is that the damage that's trapped in your body, it is trapped at a physiological level. Your nervous system is holding on to pain. And that's why when you were talking about the trapezius muscles, where people are kind of doing this, that's a lot of times where people hold their pain, is in their shoulders and in their chest, oftentimes also in their neck. So kind of at like the centralized area. Not always though. And so with EMDR, what we're doing is we're using what's called bilateral stimulation. Bi means two, lateral is side, stimulation is stimulation. So when in person, EMDR, what's going to happen is that you're going to be looking at a light bar and your eyes are going to be moving back and forth. Okay. So when you look left, you're stimulating the left side, right, stimulating the right side, and just going back and forth. I also do EMDR via televideo sessions. And so for that, I use bilateral stimulation in the form of tapping. So I have clients put their hands on their laps and tap left hand, then right hand, and back and forth. And that does the same thing. Walking is a form of bilateral stimulation, right? Because using one side of your body and the other side, which is why I personally think people invented the term "walk it off." Maybe that's where it comes from. Maybe not. And so what that does is that it starts to move and shift the body at the physiological level and helps to desensitize the client from the pain of the trauma and reprocess it. And so essentially, if you can imagine like a big spiked tower, dark, black, and icky and scary to come close to, what if you just took a hand and flattened it and spread all that stuff out to other areas? Well, now there's not this big scary thing, in the middle of your heart that you're trying to avoid. So it becomes what's called adaptive. So it gets connected to other healthy areas of your nervous system. And that way the healthy areas can heal that area. So going back to the spider web analogy, the spider would go back and from the outside start to make ways in to be able to resolve the damage in the spider web. So that's kind of how EMDR works. And what was the second part of your question, Dr. Kaye?
So when you look at somebody for EMDR, is there somebody who's not a candidate for, like, is this going to not go in the right direction?
Yes, but maybe not in the way that you would think. So for folks who have a crisis of the week and have very little ability to self-regulate their thoughts and emotions, they're not at a place where they're prepared to do EMDR. Because EMDR, like any kind of trauma work, is going to bring to the surface all the very scary things that we've worked so hard to avoid, right? And so when that stuff comes to the surface, if this person is not able to get to work on time, if they're not able to manage relationships well, and things of that nature, oftentimes, I don't like to put people in boxes, I don't like to use diagnoses, but in terms of the patterns I've seen, folks with personality disorders oftentimes have a much harder time in consistently engaging in trauma therapy. Because they have difficulties with relationships, managing thoughts, managing their emotions, and things of that nature. So borderline personality disorder, for example, right? A lot of times what I've seen is folks that suffer from that diagnosis, they need a lot of training and skill development. So DBT is a great tool for that. And to be able to learn distress tolerance, being able to be mindful, being better in relationships, regulating your emotions, those are all skills that need to be developed just for foundational work, just to live from day to day and to manage relationships. And you add on layer of doing trauma work from, let's say, a really horrific trauma, that person's going to become very dysregulated. How people react to trauma also can vary from trauma to trauma and person to person. I've had people who've gone through really difficult trauma sessions and they're like, I'm fine. They cry a tear and they're like, I need to get to work and I'm going to be okay. I've had people who've dissociated for a week at a time and didn't know what they've done for 7 days straight. So that's why developing coping skills and ways of coping are absolutely crucial before starting any kind of trauma work. And I would say it's unethical to start any kind of trauma work without having foundational supports, ways of coping, healthy routine, working on sleep, diet, things like that. So a more holistic approach so the person is strong enough, resilient enough to get in and start doing trauma work. And in the EMDR process, there are things like coping skills that are built into it.
So would you say that EMDR is a tool to bring about the repressed trauma and then to deal with that? Is dealing with that meaning is adaptive? Is that what EMDR is used for?
So I love EMDR. I'm biased towards it because I've seen it work 1,000 times. It's amazing. It doesn't require somebody to be in long periods of like prolonged exposure, for example, which is a different form of trauma. It's a different trauma modality. I feel like EMDR is a good fit for me. And in doing any kind of trauma work, it can bring to light or bring to surface memories that are repressed. I have absolutely seen that happen with clients. It's oftentimes very upsetting and very disturbing for them, which is why we fall back on healthy coping and things of that nature and natural supports. But it's really just to, once you identify an active trauma, because everybody has trauma, but not everybody necessarily has a currently active trauma. I would say many people do. When we decide, when we realize that that is an active target, then we can use information taking, gathering baseline information, the negative, positive, core beliefs of particularly that person has about themselves in relation to that trauma, and then go through the process. And it's, Dr. K, I don't need to sound, whatever, but it's almost like magic. That's how other people have said it. Like, I can't believe it's gone. I feel like it's somebody else's story. I feel like it's so far away from me now. These are the types of things I've heard people say after they've resolved a trauma. So,
and it must be wonderful to unshoulder that trauma, right? To just finally have it off. Because again, in our world, I mean, we see where this emotional trauma creates not only a gut disorder with the gut-brain axis, we see it affect somebody, neurotransmitter perspective. We see it affect them immunologically. So, we can take all the right supplements and we can do the right exercise and we can eat the right food. And again, the next level is, hey, we have to address this underlying trauma. And we can see this with our autoimmune patients, our gut functional patients, those who have IBS, and whether they're dealing with constipation or diarrhea. I find there's a lot more emotional trauma tied in with constipation than I do with those who have IBSD, which is the irritable bowel syndrome with diarrhea. So it's very interesting when we start, as one would say, getting into the layers of that. So again, though, with EMDR, is it a short time therapy? Is it 6 sessions, 8 sessions? And my thought process is, okay, so if this trauma comes about, don't we now have to deal with that? I mean, this memory came up from so long ago, and it could be, who knows, it could be a good memory. I'm hoping there are times where your clients remember something good as well, because it's great to pull that memory back out. If there's a good memory, always there's some bad stuff in there, for lack of a better term. So that stuff comes out. I remember something horrible that happened when I was young. Do we then work with learning how to deal with that? Is that come more like a cognitive based therapy?
yeah, that's a great question. So ultimately what ends up happening is that if there is a related trauma, we just make that the next trauma target, and we just repeat the process for the next trauma target. You brought up a great point. Do people remember good things? Absolutely. That's actually one of the best parts of the EMDR process, is as people are starting to resolve things. I'm thinking of a few people in mind who've had strained relationships with their mothers, for example. As they're resolving a trauma that the mother is the perpetrator in that situation, they end up remembering things like picking flowers in the fields with their mom, and going to like car shows or something like that with their fathers, like whatever it is. Oftentimes they do start to incorporate healthy and positive memories, and that's almost always a sign that trauma is starting to be resolved.
So when somebody sits with you, how long is a session when you're doing these eye movement patterns and all that? How long does that take?
Yeah, so I think normally most therapists probably run about 90-minute sessions for EMDR. I run the 60-minute sessions for EMDR. Um, um, I find that 90 minutes can be a little bit intense for clients who are dealing with some intense stuff, and I always leave room for de-escalation, having conversations, going through progressive muscle relaxation, different coping skill at the end of the trauma session. But in terms of, so let me take a step back. We want to prepare the client to be trauma therapy ready. So that's where the coping skills, diet, exercise, all those kind of wonderful things come into play. And that is completely depending on how well the client does with those things. So I can teach a client how to do progressive muscle relaxation, but if they're not practicing it, again, ethically, I cannot start doing trauma work if they're not capable of being able to manage what comes up. So I really put the responsibility back on the clients for that. Like, listen, this is an important thing. It's a painful thing. We need to work on it. This is a goal that you set for yourself. What barriers, what can we do in terms of troubleshooting to reduce the number of barriers for you to do the preparation work? So when the clients are, and when myself and the clients agree that they're doing what they're supposed to be doing with practicing coping skills, all the other good stuff, the trauma itself can take however amount of time. It's completely dependent on the person, which I think makes EMDR such a beautiful process, because in the book they might have a you know, a preferred number of sessions, but I've helped somebody resolve a trauma in 45 minutes in one session. And it was a trauma. It was an elderly woman, and she was dealing with something that she was carrying for about 40 some years. I think she was maybe in her 60s or something like that. She'd been carrying it her entire life since she was like in her 20s. We resolved it in 45 minutes. And there's other sessions where it's taken 8, 12 sessions to resolve something. And what happens is, Dr. Kaye, is that when there's what's called complex trauma, so that's, you know, something that's happened repeatedly, for over and over and over again. I have one client in mind who suffers with, you know, sexual abuse many, many times in her life. It's difficult to tease apart the different instances. And so oftentimes that pain and that energy kind of flows from one memory to another, and that can become an issue. And so that's why we try to go back to the first or the worst example of a particular trauma umbrella, and try to deal with the most intense or the first example of trauma first, because that it's on that all those other traumas have been built that make it a complex trauma. So it can be a varying number of sessions depending on what the person experienced, how long ago it was. So if it happened earlier in life, it's going to be more difficult to resolve more often than not. So there's a lot of variables that go into how many sessions it would take.
And with that layering of trauma, do you believe in generational trauma? Is that something that you see?
Generational trauma in that, like, for example, a parent who was lacking parenting skills because they weren't taught parenting skills now treat their children with the same lack of parenting skills. Is that kind of what you're referencing?
That, but more so like, you know, we see somebody who's like, for example, may have some food issues because their grandparents were in, you know, the Holocaust, and you know there was this generational trauma there that got passed on to one parent and onto their kids and so forth. You ever see that where it just continues, the story just winds again and again and again? And you know, sometimes we'll see that with, you know, clean your plate kind of deal. Other people are starving. You never know when you're going to eat again. Money is tight, and it sets up this very odd relationship with food.
Certainly. Absolutely.
Would EMDR help with somebody who has, and Pamela and I were talking about, you know, on the last one, you know, about people that have food issues. Would EMDR be able to address those relationships that are not healthy with food?
Would they be able to address the relationship? So the way that I conceptualize trauma, Dr. K, is the phrases that I look for are things like, and my life was never the same again, or that's when everything changed, right? And a lot of it also, I kind of listen for what the person says about themselves. So if somebody struggles with food and they think that, you know, I have to clean my plate because I never know when I'm going to eat next. Well, the question that I would ask that person is, what does that say about you, if that's the way you think? And that's where that negative cognition would potentially be discovered. You know, I don't feel safe. I don't have a sense of security because I don't know if I'm going to be able to eat again. That's how I grew up. So if they have that sense of, you know, I'm unsafe, I don't have a sense of security, I don't know what's going to happen tomorrow. If that's what they believe about themselves, well, what would you like to believe about yourself instead? Well, that I am secure and that I'm going to be okay, that I'm safe. Okay, well, that would be a lovely thing to believe. Now let's ask, is there anything in your life that kind of is highlighted when you think of that phrase, right? When you think of the idea of food and stuff like that, and that might take that person to a time when they were young and maybe their, you know, the parents lost their jobs or something and they were having a really tough time. Maybe that brought about a bunch of arguments in the home between the parents, you know, who knows? And so if we can find a specific moment like that, then we can address it. If there's not a moment, oftentimes what I end up doing is just do body system work. So when you think about this belief about yourself, or when you think about the idea of running out of food or not having enough food, or needing more food, what do you feel in your body? What are the physical sensations that you feel? People might say something like, my stomach gets tight, or my shoulders get tight, or my hands are getting itchy. And maybe just use EMDR to process that there. So it is a pretty flexible tool. I think you can certainly use it in a lot of different ways. Um, Obviously, from my point of view, I've worked with people with eating disordered behavior, and making sure that they have a doctor that is on top of what's going on with their health at a medical level is absolutely crucial for any of that kind of stuff. But I think EMDR can certainly be helpful.
Excellent. And a few moments ago, we talked about a diagnosis. I think you said like a borderline personality disorder. Um, I know when I was speaking with Jesse before, we talked about ADHD. So with borderline personality disorder, can you talk a little bit about borderline personality disorder and bipolar disorder and what the differences are?
Sure. So bipolar disorder is usually marked by a cycling of mania or hypomania, and then depression. So a person feels good, has lots of energy, maybe even has uh, thoughts of grandiosity, and they make a bunch of plans and things like that. They have a lot of energy. Maybe they feel like they don't even need a lot of sleep. So that's like at the manic level, and there's lesser versions of that as well. Uh, and then they kind of cycle from there down into depression. So this cycle continues to happen, and it can vary from person to person how often the cycle happens. So that is the main aspect of bipolar disorder. Some bipolar disorder also has psychotic features where people are hearing things and things like that. But again, there's a lot of nuances with diagnosis, which is why I don't try to get too much into that. Borderline personality disorder does have a genetic component also, just like bipolar disorder does. Um, the main features of that are that a person has a higher baseline for disturbance, like they're upset. Like if a normal person's baseline level of upset is here, for somebody with borderline personality disorder, their baseline is higher. They are faster to get upset or angry or to become dysregulated, and they're slower to come back down to their baseline, which again is higher than the norm. So oftentimes what that means is those people really struggle with relationships. They really struggle with emotion regulation. They really need to develop skills around that. Distress tolerance. Can you bear just being uncomfortable? Can you bear being in a difficult situation? And then just relationship skills, learning how to ask for things, learning how to say yes, when to say yes, how and when to say no. So there's a lot of education and training that can go into helping somebody with borderline personality disorder diagnosis. And it requires a lot of work from the individual's point of view.
So, and do you feel EMDR can be helpful for those types of presentations?
Yes, absolutely. They can be. Currently have clients with that diagnosis that are doing trauma work, and it's going fine. But we had to get to a place where they had strong foundational skills so that they could manage the day-to-day as well as be able to manage whatever comes up for them during trauma work.
And before we move away from EMDR, because I'm really fascinated with this topic, just from selfish reasons alone, that with the people that we see in the practice. So, a case where somebody's been involved in a motor vehicle accident, there's head injury, there's concussion. It's a known trauma. We know the root cause. It was the trauma. It was the accident. So it's not like we're looking for something that was been repressed. We have something that's very, very recent. How
Absolutely.
does EMDR play a role with that?
Yeah, awesome. So a lot of times when people have been in motor vehicle accidents, they will have trauma. I used to know a gentleman who never drove on the highways because he was in a bad car accident, and so he took back roads to get everywhere. So it affected his life because he had to leave, half hour early to get to wherever he was going. So that particular incident, that crash or collision or whatever it was, that just simply becomes the trauma target. We talk about the negative and positive cognitions, right? The negative cognition could be like, I'm not safe to drive on the highway. What do you want to believe about yourself? That I can be safe to drive on the highway, right? And then we just simply go through the EMDR process for that trauma target, which would be the accident. And that person more than likely would be able to resolve it. They could still choose whether or not they want to drive on highways or not. One example that I'm thinking of, there was a gentleman who was rear-ended by a 16-wheeler. He was sitting at a red light. The truck didn't stop. It accordioned his truck completely. Mm-hmm. He walked with a limp for the rest of his life. Well, that was a trauma target that we worked on. And what he said to me was, after resolving the trauma, there was less pain in his leg. So did it heal his leg? No. But if your body's holding on to not only the physical damage, but also the trauma damage, right, the emotional damage from that, then being able to resolve that at a clinical level is going to help with that piece of it. It's not going to heal bone or, mend a ligament or anything like that. But he said he was able to walk with less pain, which, I mean, I didn't know I was beside myself with happiness to hear that.
So with the eye movement, are you ever concerned with the rapid eye movement that you're actually going to, or maybe patients have said it before, that you're going to create a migraine, like almost like a migraneous event from the rapid eye movement? Because in our world, eye movement is tied directly into cervical spine range of motion. Eye movement tied directly into occipital pain, supraorbital pain. So are you ever concerned that with this eye movement, you're going to actually just create a migraine presentation?
Yeah, that's a great question. So before we actually do any eye movement, we always do a test. So in terms of distance between the clinician and the client, we make sure that the distance is good, the range from side to side is good. So it's not like they're almost tempted to turn their head to see it. So we have to get a good range to figure out what's going to be comfortable for their eyes to move in within that range. And then what we do is we figure out what speed is going to be comfortable for them to be able to maintain. And on top of everything else, if at any point a client tells me, hey, listen, this is starting to hurt my eyes a little bit, let's take a break. No problem. We'll take a break. Let's talk about how we can make it more comfortable. Slow it down, maybe make the range a little bit shorter, right? Whatever we need to do to make the person comfortable. And for some people, if they have medical issues with their eyes, we can just switch over to tapping instead.
Okay.
So it doesn't have to be eye movements. Like I've exclusively been doing it over video telehealth for the last several years and resolving just as many traumas as I was when I was doing it with eye movements in person.
And do you feel that working virtually, you lose something with the body language? Like, because you always thought, the hands folded over, the tapping of the leg, you ask a question or looking up here for the answer. So do you find virtually that you lose something, where it's just so comfortable now doing it virtually? Like, is there anything that you feel that you're missing?
No, I don't think there is. And I think that most people would say, well, there's obviously a difference. And I would agree with that. There's obviously a difference. But when I'm doing video sessions, unless the person has their phone right here, I can usually see a majority of their body. And one of the things that we talk about is, hey, listen, because I can't necessarily see all of you just by like looking around my desk, if there's something going on, the example that you gave is perfect, like your leg is shaking, please let me know. Because if that is maybe due to a side effect from like medication or something like that, tell me so we can talk about it. If there's stuff going on that I can't see, tell me. And that usually covers issues. I haven't had any major issues with that. For the EMDR stuff, I ask people to put their cameras at a place where I can make sure that they're tapping at an appropriate speed, because sometimes people tap too slow and we need them to tap a little bit faster at a faster pace. So being able to see the person's body is exclusively how I do EMDR. So I can see their hands on their lap, I can see their face. And it lets me see like if their arm is twitching or if they're making facial expressions of pain or something like that. And then we can bring it up and talk about that as we need to.
And one of my patients brought up a wonderful point, because I was talking about how easy it is to have virtual therapy now. And the reply was, yeah, I can see that, but I'm still in the house, so you never know who's listening.
Oh, sure.
It didn't feel like they could truly open up because it wasn't in a private setting. So what kind of like rules do you handle, give to your patients? Like, hey, if we're going to do this, this is kind of your environment.
Yeah. There's a baseline standard, which is there needs to be privacy. You deserve privacy. And we are going to behave as though we were meeting in person. So there's not going to, you're not sitting there with a drink, an alcoholic drink in your hand or smoking a cigarette. You wouldn't be doing that in the office. So we still keep it professional. Rules about making sure people are appropriately clothed and all that kind of other stuff. So the environment is important. It's something that's discussed to make sure that it is regulated in a way that is going to promote privacy and the safest therapeutic environment as possible. So for all of my trauma clients, even for my regular clients, like unless somebody wants somebody to be a part of the session, then that's their discretion. They can have their husband or wife or whatever join their session if they want to. But if we're doing trauma therapy, especially for that, I make sure people are alone in a private place where there's not going to be any kind of foot traffic or disturbance. I oftentimes ask folks, if you feel comfortable, please lock the door so no one barges in, and maybe put on some headphones so no one else can hear what we're talking about. You can have the privacy of your conversation just between you and myself. I always wear, a headset or something and a microphone, noise canceller or something like that is going on. So it's completely private on my end. It's completely private on your end. And now we can be open because the environment is safe.
Excellent. And have you ever seen EMDR not work? Like you touted how wonderful it is, but
Yeah.
I have tools that we use in the office, but hey man, sometimes things just don't work.
Yeah. The biggest reason why I've seen EMDR not work is because the client didn't want it to.
Gotcha.
They were afraid to approach the trauma. They didn't prepare practicing coping skills. They had difficulty with being mindful of their bodies, which is why I spend a lot of time developing specific coping skills that help them to develop that skill before we even start the EMDR process, right? So EMDR has a coping skill, for example, called safe place installation. Well, that involves tapping. It involves becoming aware of what you're feeling in your body. So even before we actually get to the trauma processing, we're working on all these little pieces that we need along the way.
Wonderful.
So if a person has a really hard time with that difficulty, or again, most often unwillingness to work on that stuff, that's majoritively why I've seen EMDR fail.
And please explain that EMDR is not just like something like a certification that Joe Blow can take online, right? So can you please explain like how you actually became EMDR certified? And we don't see a lot of it. I mean, I know a few practitioners, but I don't know a lot of practitioners.
Okay. So just for clarification, the certification for EMDR is a much lengthier process than I went through. It requires more training and tests and more supervision. I did the foundational EMDR process, which was still pretty extensive. It was a full weekend. This was pre-COVID, so I went to a training center down in the city, Philadelphia, and I think it was through EMDRIA, and so it was a weekend-long training. And then there were 6 months in between where they told us to practice EMDR, so actually use the skill. And then after those 6 months, there was a follow-up weekend-long training where we did additional training stuff. And all along the way, we actually had an EMDR therapist as a supervisor that we met with I think it was on a monthly basis, to talk about what difficulty we were having with EMDR, what successes we were seeing, and just talking about troubleshooting to make sure that we were going and using the process appropriately.
And you yourself have been through EMDR as well?
So that was part of the training, was that we had to play the role of the client as well as the role of the clinician. So we took turns doing that. So there was a time where they said, can you bring up some like a minor annoyance or something like that? And so we did a little bit of work with that, and it was good to experience what that feels like when that openness or that relief, when that weight's lifted. It's like, wow, that feels really nice. So yeah, I did experience that in my training.
Excellent. So we're going to move away from EMDR now because I have a couple more questions. But to summarize EMDR, the eye movement desensitization and reprocessing, it is definitely a tool that can be utilized to help with trauma. So to bring about repressed trauma and then to address that trauma and move forward. Would that be like a summary of that?
Yeah, so I would say that just generally speaking, when people start bringing up trauma, it can happen where repressed memories come up. But more often than not, people have clear, specific targets of events that happened that we just use as targets. But yeah, all of that is absolutely accurate.
I love the fact that we get to bring it up and create a coping mechanism pre and post. I think that's absolutely fantastic. So you're almost like prepping the individual, getting them ready for the event, bringing about the event, and then dealing with the event, and then moving forward to the next level.
That's a great summarization, Dr. Kaye.
That's fantastic. Okay, so on your website, you have something called Trauma Art Narrative Therapy.
Yes.
I have to ask, what is that? Because when it comes to art, I can doodle is the best I can do. I can give you a bicep. I can give you some pec muscles. I can draw a humerus, but asking me to like give you art, I'm traumatized just by you asking me to give you art. It's just not in my brain. It's not in my hands. It's not my skill set. So, what is trauma art narrative therapy?
Well, Dr. Kaye, that's something, that phrase those phrases I haven't heard in a little while, because that is always the first thing people say when I've talked about trauma art narrative therapy. They say, I can't draw. And I say, you don't need to. You having artistic, what I have noticed in trauma art narrative therapy is that the folks who have artistic skills often struggle more with the trauma art narrative therapy because they're trying to incorporate shading and detail and perspective and all these kinds of things. The tools, when I do trauma art narrative therapy, the tools I'm handing you is a piece of paper and crayons. Okay. And so what trauma art narrative therapy is, it's art narrative therapy. So what's happening is that you're essentially making a storybook. And the storybook is about the event, the trauma event that you experienced. So what happens is that there's a certain procedure in terms of how the artwork is drawn, but you have to be in every single picture. Have as much detail as possible. You're welcome to use as many colors as you want. And so we kind of go from the outside in. So the last picture the person draws is when the actual trauma happened. So we kind of sneak in on the trauma from both sides. And so after all the artwork is done, then we do the narrative piece, and that just goes straight from, beginning to end. And the person writes back on the back of each of those drawings, what was happening in that drawing, what they were thinking and feeling in each of those pictures. And then there's a story sharing aspect where the clinician will read the person's story. So, just like in kindergarten when the teacher's holding up the picture book and reading, we're doing that same exact thing. The clinician is doing that for the client, and then it's client's turn to do the storytelling. And then we finish up with an art analysis piece that happens at the end where we talk about what kinds of themes and things like that we noticed in the artwork itself. And this is where I originally, my first training was actually in trauma art narrative therapy. That's what got me into the trauma field, because it did open so many doors for me to be able to actually help people resolve traumas. And then from there, I found interest in EMDR, and then that was just like just another way to do it. So if one modality didn't fit somebody, maybe the other one did. So I hope I answered your question there.
Yeah. So have you ever looked down at somebody's art and they're telling you the story of what that is, and you're looking at this and go, wow, it's discordant. It doesn't jive. Like your story is not jiving with what they drew as a representation. Do you ever see anything like that? Or is it pretty much like what they draw is pretty close to their narrative? It's close to their narrative, I'm guessing.
Yeah. So the only times I've noticed where the artwork really didn't match is when clients had either some kind of biological damage to their brain. Like there was one gentleman who had several concussions, and I think he was also dealing with dementia. So like his artwork, he says, oh, I drew this, and I'm looking at him like, that's just like a circle. Like, okay, so maybe it looks like that to him. It doesn't look like that to me. But right now for me, that's not what's important. If he can see it in his drawing, that's what matters. That is a very real difficulty. I also had some clients who struggled. They were able to do it. One client in particular I'm thinking of, who had Down syndrome, really struggled to kind of understand and follow the guidelines for the artwork. But we were patient and we were able to get through it. And he was able to resolve a pretty major trauma. And, his family said that they really noticed a big change. He wasn't having nightmares anymore. He wasn't having anger outbursts like he was before. So there are some barriers. There may be some more limitations to the trauma art narrative therapy when it comes to that kind of stuff.
Gotcha. And also on your website, you have solution-focused brief therapy.
Yes.
So this sounds like, man, I'm in and out in 10 minutes. I'm going to get everything all cleared out. I'm going to be good to go. It can't be that simple.
Well, so solution focus is a very interesting therapy modality. They recommend like around 12 sessions, you're done. So the idea is it's always focused on solution building, right? Where the language is very different from other types of therapeutic modalities. So it very much focuses on what's good, what's been better, how did you keep it going, right? What's keeping it from being 1 degree worse? What do you know about yourself that lets you know that you can be successful in this endeavor? Like, the language is just different. I really do enjoy incorporating it in mixing it with other kinds of trauma therapies, but it's very much solution oriented, and it very much puts the client at the center of all of the work. All of the language that the clinician uses is a reflection of the language that the client just used. So
Interesting. And you bring about language, and I think language is really important. And I will often hear in my office more from females than males. So, oh, I'm sorry. It's like the chair was moved in a different way. Like, oh, I'm sorry.
sure.
We hear, people who say, they dropped something. I'm such an idiot.
Mm.
This language is like, I failed at that. And I was like, well, you didn't fail. It was just an experiment that didn't turn out the way that you wanted to, right? So we hear like, I'm stupid. I'm a failure. I'm
Yeah.
sorry. I got this wrong. So language, when somebody brought that up to me, I'm like, I never paid attention to it before. Now I pay attention to it all the time. It's like, when somebody said, hey, your friend's ears are big. You're like, no, it's not. And you're looking like, oh my God, his ears are like Rottweiler ears, right? So I listen to this like language all the time. Then I start wondering, my God, I wonder how many times I've said that about myself.
Yeah.
Because if somebody called me an idiot, I'd be like, hey, don't call me an idiot. Don't call me a moron just because I dropped something. So can you touch a little bit about language and what you may hear in a session? I know it varies, but just touching base on language and how we can just say nicer things about ourselves. How do we develop that skill set?
Yeah. The very first step would be mindfulness, becoming aware of the fact that you're doing it. You can't really solve a problem if you don't see the problem, right? So that's always my first encouragement for folks is, listen, I'm hearing you talk really, really poorly about yourself. And Dr. K, your example was perfect. If somebody else said this to you, you wouldn't accept that from anybody else, but why are you
Right.
accepting it from yourself, right? So you kind of become your own worst enemy, and you're trapped in a room with them up here, and they're always saying bad stuff about you. That's not great. So really, I try to encourage mindfulness, become aware that this is happening, and let's normalize whatever's going on. So a lot of the examples that you brought up were very much identity-based stuff. Well, where does that thinking come from? Why do you call yourself a failure just because you dropped something? Where does that come from? And that might lead to a damaged relationship from the past. It could just be, really high expectations of themselves. It could be a lot of different things. And so we can then talk about normalization. What language actually reflects reality? Are you a failure because you dropped a pen, or did you just accidentally drop a pen? Right? How much worth are we putting on these things? And how we're treating ourselves after that is not so great. So let's adjust this. Let's have you become your number one cheerleader first, and encourage yourself to do good things, and reinforce that, as opposed to putting yourself down all the time.
That's beautiful, because I can tell you physiologically, just being angry all the time, getting pissed off all the time, it's just not good for the gut, right? I mean, it gets
It's
us
not-
absolutely nowhere,
yeah.
whatsoever. So the other thing that you have on your website, and this can take us into a whole other hour, but I want to be respectful of your time, is you have Christian counseling.
Yes, sir.
So how do you see Christian counseling? And I want to touch base on, because in my office, it's interesting because those who are most religious have a tendency to be those who are the most worry and anxious. So I kind of struggle with them, like, well, if you have good faith, then you really shouldn't worry so much because you have good faith. But they are, right? They're really worried, they're anxious.
Yeah.
But yet at the same time, they'll tell me, they do this at church, they do that at church, they do their prayers every day. I'm
Yeah.
like, well, it's wonderful. Then why if you believe in, I'm going to just say it right now, if you believe in God and you have a relationship with God and you feel God takes care of you, then what in good's name are you worried about? What in God's name are you worried about?
Yeah. That's an amazing question, Dr. K. I appreciate it. Um, I think that dependence is humility and dependence are not emotions or states of being that make us feel empowered, right? The idea is that when you have a relationship with God, that you're dependent on Him. You trust in His timing, you trust in His provision, you trust that He is going to give you what you need and then some. But we as people aren't very happy with that. We're not very patient, and we have a tendency to drive the narrative ourselves, right? It's a very much like an American ideal where you pick yourself up by the bootstraps and you make it your own way. I'm going to I think Frank Sinatra sang a song that was titled something like that. I did it my way.
Yep.
That's the mentality. Do it yourself. Go make a life for yourself. Go be successful for yourself. Do it by yourself. And so the idea of being in complete humility and dependence on someone or something else, it's almost alien to us. Like we reject and we fight that every way we can. We try to take control of every situation as much as we can. It happens all the time. Sometimes it happens without us even knowing. And so for folks who struggle with anxiety, I think that's the biggest thing is like, you can trust God that He loves you and He'll provide for you. And there's so many scriptures in the Bible that speak to that. You don't have to be anxious. Don't be anxious for anything. Don't be afraid of anything. Be brave, be courageous. And so for my Christian counseling work, it's my honor to be able to pray with my clients at times, and to encourage them to pray, which is great because, they're devout Christian, they go to church and all this kind of stuff. But sometimes you just need somebody to remind you, hey, it sounds like you're really worried about this. Did you go to your husband and pray together? No, I didn't. How come I'm not doing that? I don't know why you're not doing that. Let's do that. Let's pray together about this, right? And so simple reminders like that can be helpful to address things like anxiety. You don't have to you're not alone. First of all, you're not alone. You never were, you never will be alone. You always have somebody there with you who loves you. And you can be in a community of people who love God, and God loves them too. And you can go through life together. So you're never alone. So you never have to deal with anything alone, right? So go pray with somebody, pray together, be in a community, go to church, things like that. That's what that's for, to develop that community.
I have patients who I'll ask about meditation, and they'll say, "No, I don't meditate. I just pray." I'm like, "Well, that's kind of like a form of meditation, right?" And they're like, "No, it's prayer." I'm like, "Okay." And we've had some patients when I told about yoga, they say that they don't want to do yoga, and I'm hoping that maybe you can answer me this and expound this. They say they don't want to do yoga because that's allowing Satan in. And I don't have an explanation other than, okay, I'm not going to fight it. I'll find a different way for them to do a down dog, right?
Sure.
So what is the best explanation for that?
Yeah. I just had this conversation with somebody recently, so I'm glad I did, because now I have an idea of what I want to say. So the idea is that yoga is, if you look it up, yoga is a practice that is synonymous with Hinduism. So I was born in a Hindu family. I was born in India, so I was born in this. So when people are saying things like namaste and chakras and this and that kind of stuff, like I was raised around that stuff. I'm a Christian now, but the idea of yoga is a practice that's integrated within the Hindu religion. So for the Christian clients who are coming and saying, like, I don't want to do yoga, like I'll do stretches and stuff, but I'm not doing yoga. It's not just an issue of going through particular motions. It's the inseparability of the physical act of doing the yoga stretches, which, they have things like saying good morning to the sun or worshiping the sun. That's goes in the opposite direction of Christianity, because at that point you are now worshiping creation instead of the creator. And because those things are so closely linked, I can understand why some of the Christian clients might have difficulty with accepting doing something like yoga.
So just switch it around then. Like, here's just the stretches. You don't have to do yoga.
Yeah, people have asked me that same question, and I say, listen, there's a lot of different ways you can stretch your hamstring that doesn't require you doing this particular pose from yoga.
Correct.
Right. And that's you're the expert in that field. I would defer to you about asking different variations for different kinds of stretches and things like that. But yeah, I encourage people, do your research, talk to your doctors, talk to Dr. Kaye. He'll help you out with that kind of stuff. But it doesn't, they're concerned, like, man, people are telling me I have to do this yoga stuff for, my health. And I'm like, if you feel strongly about this and understand why you feel strongly about it, talk to your doctors about different ways to do the same stretch.
Right. And there is. I mean, there's so many different ways to
Exactly.
stretch and move and breathe and meditate. And there's so many different ways of doing it. We just want somebody to embrace something and start something and do it, right? Even if
Yes.
it's just walking outside, we just want to get them moving and breathing and just, being their best self is what we want to do. So one of the questions I had is like, and we talked before when speaking to Jesse, we say like, how do we find a good therapist? So my question to you is like, how do we know when to move on from a therapist? Like, how do we know like, hey, we hit our plateau. I mean, we're not moving forward. So as a consumer, how do we know when it's time to change, when to move on?
Yeah. So just answer that question. Let me start with some red flags. So if the therapist is doing a lot of talking about themselves, that's a red flag. If your therapist never challenges you, that should be a red flag. So if you go in and you basically paying somebody money to say yes to everything you say, you're not going to make progress there, right? So those would be the two main red flags. So if there's issues with boundaries, issues with ethics, if they're not challenging you and helping you move towards your decided goals, those would be reasons to move on from a particular clinician. Those would all be, those first two are definitely red flag issues. But if you are going in and you're talking to somebody and it's like talking to a friend, go make a friend. We should be, as clinicians, we should be encouraging people to have natural supports like friends. It's not our place to take the role of the friend. Because as a clinician, if you come to see me, I'm going to make sure that we're moving towards and making progress towards the goals that you set for therapy. Now, if that requires me to challenge you or call you out on inconsistencies or potential problematic patterns, I'm going to do that. I'm not going to be afraid to do that because it's for your benefit. So if you don't have a therapist who challenges you, says yes to everything, they're just really friendly person to talk to, that's great. And that might be what that person needs at that time. But if there's particular goals that you want to move towards and you feel like that progress isn't happening, then you need to find a different clinician.
Beautiful. Got it. And I have one last question for you. Well, I have two. Actually, one is, what book are you reading now?
I'm reading Systematic Theology, which is a very thick and heady book about theology. It was written by Wayne Grudem. I'm currently in a study group through my church. It's myself and 4 other gentlemen. We're going through the entire book. It's about this thick. And it's going to take us about a year and a half to go through it. We meet once a month to review 4 or 5 chapters at a time. It just talks about different things like the divinity of God, the authenticity of the Bible, different aspects of God, things like sin, creation, all this kind of stuff. And that's what I'm reading right now.
Beautiful. Light reading.
Light reading. Yes.
Okay. Which will lead me to 20 more questions, and I'll wait for the next time. So the last thing is, can you share with everybody how they can get in touch with you, how they can work with you?
Sure. You can, the easiest would be to go onto our website. All of our contact information is there at Hope Stream Counseling. Currently, we have 3 active counselors. We just hired a new one. We're very glad to have her on. And there's a pretty decent area of expertise that we all have. I think we all have background in trauma, which is wonderful. And in our own particular specializations and things like that. So come check us out and we'd be happy to help.
Excellent. Thank you so much for tonight. I had a wonderful time, just a wealth of information. This was really great. So everybody, this is Dr. Michael Kaye from the Center for Functional Health, and we will see you soon.